Welcome to Progenesis Academy webinar session 32. Today we have a very interesting topic. Does Mosaicism impact IVF outcome? We are very fortunate to have a panel of fertility specialists and embryologists that will help us understand the clinical implication of transferring mosaic embryos. Today's webinar has about 235 registrants and more than 40 patients. And the rest are embryologists and physicians. And with this, I'm gonna take the opportunity to introduce our panel. We have with us Dr. Deng. She is the fertility specialist at Stanford University. Dr. Quaas, he is the fertility specialist at Reproductive Partners Fertility Center in San Diego. We have Venier. She is the co-founder and director of trainer at World Embryology Skills and Training. We have Dr. Pomeroy, he's the scientific director at the World Egg Bank. We have Tony Anderson, he is the lab director of embryodirector.com. And we have Dr. Wiemer, he is the lab director at Poma Fertility. Thank you so much. So I'll start my first question for anyone in the panel to define what Mosaicism is in the context of embryo testing. So I'll start with maybe with Dr. Deng first, and then I go to Dr. Quaas, and then maybe we go in through the panel.
Yeah, so I think like based on the definition, it's like a presence of two or more cell populations with a different genetic composition in an embryo. And it depends on what platform, like usually it's diagnosed or reported by the PGTA technology. And based on the cutoff or threshold different laboratory are using, sometimes they use like a cutoff 20 to 80% of normal cells in or say abnormal cells account for 20 to 80% of the whole cell population. Some laboratory use 30 to 70%. So I think it's different laboratory dependent, but basically it's kind of a mixture of different cell populations in the embryo.
Thank you so much. Dr. Quaas?
Yeah, I would completely agree with that. And I just want to maybe sort of read a definition from a paper that sort of expands on that. And that is the Mosaicism is the presence of more than one distinct cell line within an embryo, each with different chromosome counts as a consequence of chromosome segregation error during mitosis, meaning after fertilization. So I think it's important to note that obviously the initial process of fertilization is a continuation of meiosis. And then once the embryo starts to divide, it also goes through mitosis, which is a different biological process. And so chromosome segregation errors can either happen during meiosis or mitosis. And usually mosaicism is a result of chromosome segregation errors during mitosis. Now, essentially for the patients that are attending this webinar, I think it's important to note that basically a blastocyst has two parts, the inner cell mass. Oh, this might not show up very nicely, but anyway, the inner cell mass, which is part of the blastocyst, and the trophectoderm, which is the early placenta. And many of our informed patients, if they're attending this webinar, they've maybe seen a blastocyst under the microscope. And when we do PGTA, so when we do genetic testing of the embryos, we sample the trophectoderm, so the outside of the embryo, the developing placenta, and that result tells us hopefully something about the chromosomal makeup of the inner cell mass, which is the baby. The thing is, and this is important to understand in the discussion of mosaicism, there's usually about 5 or so cells sampled at once from the trophectoderm, and the whole blastocyst has about 150 cells. And these 5 cells are analyzed together, which means there can be a mix of chromosomal makeups. And so essentially it can be seen as an intermediate category between euploid, meaning 46 chromosomes, no abnormalities, and aneuploid, which is not 46 chromosomes. And so it's a complicated topic. It's very confusing for patients and maybe even for providers. And so it's good that we're talking about it today.
Thank you so much. Going now towards the rest of the panel, if anyone wanted to define Mosaicism, we're here to hear your,
I think they both did a really good job at describing exactly what Mosaicism is, but I think they both hit on two key points that really shows the variation in what we see from lab to lab. And Dr. Deng said that different labs report Mosaicism at different levels. So some labs, genetic reference labs, are reporting a mosaic embryo at anything over 20% mosaic, and other labs are reporting Mosaicism at anything over 30% mosaic. And some who are blinded and not even receiving mosaic data are getting a normal embryo at something that might even be 35% mosaic. So some labs may be transferring mosaic embryos, but they're called euploid because they have blinded themselves to getting the mosaic data. That's point one. Point two, with Dr. Quaas, what he very eloquently stated is that it's a mitotic error. But what you need to understand is mitosis happens every few hours, depending on the stage of the embryo, and that mitotic error can happen at the 2-cell stage. And if that mitotic error happens at the 2-cell stage, then half the embryo is going to be mosaic. Not a good plan. But if the mitotic error happens at the 8-cell or the 16-cell stage, a very small portion of that embryo might be mosaic. And a large portion of the embryo is healthy and happy, and there can be self-correcting, and a totally healthy embryo could be there. So the key there is, when is that mitotic error? We don't know. But if the mitotic error is later in embryo development, around the 8 or 16 cell stage, that's very important because it's not going to be as mosaic.
Thank you so much. Let me address this from a laboratory perspective. Does the laboratory condition contribute, or can the laboratory condition contribute to mosaicism rate? Dr. Viemer?
Yeah, absolutely. That's one of the things that we look at all the time in labs. That's why just for the patients that are out there, a lot of laboratories are going to receive results comparing their clinic to other clinics in terms of euploid, mosaic, and abnormal embryos. And this is really good data to get, because what it allows is every lab to kind of compare themselves, to their colleagues. So in other words, patients that are under 35 get compared to patients that are under 35 nationwide. The reason why this is really important is that, like Nabil said, we can actually create conditions in the laboratory that would could actually increase the incidence of mosaicism. So by being able to compare in our laboratories how we do, we can kind of see if things are going well or we're starting to drift. So some of the things, though, that can impact how cells divide, and Debbie did a really nice job of explaining how this is an occurrence that's associated with cell division. So for example, if the pH of the culture media or the temperature that the eggs are held at, or even embryos are allowed to cool down, any transient heating and cooling of embryos or transient pH shifts, is because, again, Debbie illustrated that cells are dividing all the time. So if you have an embryo with, say, 100 cells in it, and you expose it to 2 to 3 minutes of abnormal temperatures or pH, you're going to have an impact potentially on those 100 cells. Now, what happens after that, we don't know. Where this is really bad is if we affect the quality, impact the oocytes and very early developing embryos, because at that point, all the daughter cells could potentially be impacted by this as well. So the laboratory can induce some of these changes that are already prevalent.
Thank you so much. And I'm going to ask you, Dr. Pomeroy, the same question, but with a little twist. the condition of the laboratory, if they do contribute to mosaicism, is this a biological mosaicism, or is it a stress and issues that are going on in the embryo during the cell development? What is your take on that?
Well, I think there's no denying that there are differences in mosaicism rates in labs, even when using the same cutoff values. But I've looked at the research and I can't find any good research that says temperature. Sure, it might. We have theoretical reasons, or pH, there are theoretical reasons. But when you look at all of these different factors that go on in the laboratory, I have not found any good study that goes and says, yes, definitely, the type of media affects the mosaicism rate. So I think we have more work to do. And then there's the other part that I think you mentioned, and that is whether other things that we do in the sampling process may affect it. And maybe those are things. Maybe we, maybe at least affecting something like the aneuploidy rate, or may have to do with the laser, how we use the laser, how high we've got it set. But I haven't seen a good study that anyone's really looked at that yet and tried to look at the aneuploidy rate after they've hit a cell very hard with a laser. But those are potential things. Or maybe there's DNA that's left around because we often use the same needle, the same probe for moving the cells that we biopsy out. And that may cause some artifacts.
Yeah, talking about studies, I think there is a study by Jason Swain on the culture media influence on aneuploidy. Riley, I sent you the link. If you can just open it for a second so the audience can have a look at it. I'm sure there is another paper that is also in the same direction, where they attribute this to differences in pH and other culturing condition that may influence or add additional stress to the embryo. Actually, I sent you a link, Riley, if you can click on the link in the chat.
Of course.
That's the paper I was referring to.
Okay.
I think John Whitney also has a study out there where he tried to induce aneuploidy or mosaicism based on the laser pulses, the number of pulses, and the setting of the laser. And he was not able to get some of those to become aneuploid based on the technique. But he did find that I think it was the spinning off of the cells and the excessive manipulation of the cells that he found. I think 3 out of 10, he was able to get the read to be different.
And this is probably one of the best reviews out there on this subject. If you look at Jason Swain's review, he looks at media, he looks at pH, he looks at temperature, osmolality, all the studies that have been done. And I think his conclusion is pretty much that we really don't have any smoking guns. There are ideas, and theoretically they might affect the aneuploidy or mosaicism rate.
Perfect. Okay. Let me take Tony Anderson, if you could give us your inputs in this. What do you see in your lab? Can you attribute mosaicism to culturing condition in your lab, or is this a possibility?
You know, I was originally trained by Klaus, so he and I think a lot alike in the sense of, you know, pH, osmolarity, and temperature are the 3 key things before you do anything else in the lab. I have not read that paper by Jason, so I'm anxious to go take a look at that. And just like Kim said, there's, you know, I can't prove from my data, but I have the fortunate opportunity to work in a network of fertility labs in the Prelude network. And I know between all of our labs, say like in my lab, if I biopsy on average of 4 embryos per patient and another lab biopsies an average of 6 embryos per patient, does that mean that that lab B is better than my lab? And I would go as far out to say, no, I think, we both have the same number of eggs. We culture the embryos out. But one of the things I noticed is that they will also biopsy poor quality embryos. So from that, they also tend to have higher rates of aneuploidy and higher rates of mosaicism, both low and high. So whether it's lab conditions or it's just pressures from the docs to biopsy more embryos or the goal to just get as many as you can. I tend to have, I personally think it's a fairly low mosaic rate. We'll look into some of the data here, but it's around 8% overall between low and high mosaic. And that being said, I only biopsy like the good quality embryos, A and B embryos.
I think there's another factor that can affect it too. The number of cells that you biopsy, that for sure is going to affect your mosaic rate. Because if you pull half the embryo, you have a much higher chance of finding mosaic than if you pull one cell out.
Well, I don't know if you noticed, but in the question and answer session, I just answered a question and someone said, I only biopsy one embryo. I never get a mosaic. And I was like, well, of course you're not going to get a mosaic. If there's only one cell, there's no chance of there being a mix. So you may never get a mosaic rate, but it's not going to be an accurate representation of your whole embryo. So yes, the more cells you take, the more accurate representation it might be. But of course, you don't want to take half the embryo. It might be a pretty good representation of what the embryo actually is, but your embryo may not survive. So I think that the going lingo is somewhere between 4 and 6 cells or 5 and 7 cells for how many cells should you be taking.
Yeah, a couple of years ago, I had the theory that the laser was causing higher rates of mosaicism. So I started doing what we call I call it a snap biopsy. And when I looked at that data, my data, I was the only one in the lab doing it compared to all the other folks in the lab using multiple different lasers. There's no increase in mosaicism or decrease in mosaicism with when I do it versus anybody else. So, along like what Debbie was saying, I don't believe that the laser actually causes it and causes really any harm.
One thing.
I love your snap.
Thanks, Debbie.
One thing I'd like to add also is the role of the platform. Obviously, I'm assuming that we're now mostly talking about next generation sequencing, but reading the literature on mosaicism, and of course I'm coming more from a clinical perspective. So I'm usually the person who goes to lectures by people who are lab specialists, and then I take that lecture, so I can only sort of trust what people like the experts in this group say. But it seems like the earlier platforms like Array CGH, qPCR, and others had a poor detection rate or sometimes inability to detect mosaicism. And now we have next generation sequencing. And from my reading, it appears on the resolution as well, and now we have higher and higher resolution next generation sequencing. So in one of the commentaries that I read, it was asking the question whether some of the information that we get has more scientific rather than clinical relevance, because the higher the resolution gets, maybe the more likely we are to detect more mosaicism, but then it needs to be put into the clinical context. So maybe the lab experts on this panel can comment on that.
Any comments from the lab? Let's go into mosaicism rates, and I'll get back to that point because I like the idea of comparing platforms. But what is, if I ask the panel, what's your mosaicism rates right now? And I'll start with you, Tony. Do you know your mosaicism rate?
Ours is around 8% overall, 8%. High and low mosaic.
Debbie?
I'm not with the clinic anymore, but when I was with the clinic, it was about 6.5%.
6.5. Klaus?
It really depends on what platform I'm using.
Yes.
But typically we're running a little under 5% when I get the raw data, but it really varies by genetic company.
Very good. Any idea, Kim, what's the mosaicism rate in your organization? Oh, actually, you probably don't have that problem because you're
Well,
egg
I
donor.
work with 2 IVF clinics, but they're too small to really be meaningful.
And how about the physician on this panel? Do you know what the mosaicism rate is in your organization? Dr. Quaas?
Yeah, less than 10%.
10%.
Also, I think it's also important to look at another parameter, and that is the percentage of patients who do PGTA, where a mosaic embryo is the only available embryo for transfer. So basically, what percentage neither have all aneuploid embryos, nor a mixture of aneuploid and euploid embryos and maybe mosaics, but how many patients have only aneuploids and then mosaics, where you have to make that clinical decision whether to proceed with a mosaic transfer or do another cycle? And I think that rate is about 2%.
Yeah, 2%. Dr. Deng?
I think our mosaicism rate is anywhere between 6 to 7%.
So if I look at the panel, just the panel, it's somewhere between 5 and 10%. That's the mosaicism rate we're talking about.
But that's just the panel. If you talk about what happened in the I3 webinar last week, they were showing ranges from anywhere from 4 to 30% mosaic in some places. So it varies a lot higher than what it appears on our panel here. We're very like-minded here in this panel. So. Yeah,
and just to touch base on the question that Dr. Quaas pointed, you draw a comparison between old technology and the new technology, but what Klaus was saying, that within the new technology, the NGS, also you see variability between platforms and between labs. And
exactly.
Yeah.
In the resolution.
So, exactly. So we looked at the miscarriage rates, mosaicism in miscarriages. And I think, Riley, if you can point that study on miscarriages, I think it's slide number 3 or 4 in that PowerPoint. So this is a study looking at over 1,000 patients. And what they did, they took a CVS tissue and they did short and long-term culture. And they were just asking, what is the mosaicism rate? Next slide, next one. Yes, this one. So what they found in this study, looking at over 1,000 patients, and this is, I think, natural conception, is not even IVF, it was 3.5%. That's the rate that you would expect in natural conception. And the question is, do you expect a similar mosaicism rate in embryos? And so I think that's the figure I would like to put there. Now, let's look at the clinical decisions. How do you guys decide what embryo to transfer if that embryo is mosaic? Do you transfer mosaic embryos? Dr. Quaas?
Yes, so the answer is yes. I do, and we do as a group transfer mosaic embryos. As I said earlier, when a patient arrives at the junction where all they have available for transfer is a mosaic embryo or one of several mosaic embryos versus doing another cycle with the goal of generating new euploid embryos. I think that, when you look at the conservative recommendation from societies and, what we as experts should probably recommend, our sort of default recommendation should probably be to do another cycle rather than transferring the mosaic embryo. But of course, we all know that every IVF cycle is an emotional, physical, and financial investment. So not everybody is independently wealthy. And of course, some of these patients have already done 1 or 2 or more prior cycles. So if the patient, after counseling, feels like she would rather, or the couple would rather, transfer mosaic embryo than do another fresh cycle with the goal of producing euploid embryos, then I think it's important that the patient or the couple receives detailed counseling from us, but also from a genetic counselor. Because I feel for our patients nowadays. In the old days, I mean, of course, our success rates are better. So, you know, our field is in a better place. But nowadays, you almost need a molecular biology degree to be a patient, an infertility patient, because, I mean, how on earth do you understand all that? You know, because you need to not only know what a blastocyst is, but then also have some understanding of the genetic testing techniques, et cetera, et cetera, et cetera. So I think the importance of genetic counselors has massively increased with this increased complexity of our field. So, and when they do that, and after they complete that counseling process, and it has been documented, then I feel like we should feel comfortable transferring mosaics.
Thank you so much. Dr. Deng?
Yeah, so at Stanford, we actually have an ongoing like a research. It's called TAME, T-A-M-E, transfer of abnormal and mosaic embryo. So all these like transfer of a mosaic and abnormal embryos are done under this like research protocol. So any patient, if they desire to transfer abnormal or mosaic embryos, they will actually have a counseling with our genetic counselor. And we gather all their like this couple's like family history, genetic information. Do they have a karyotype available or not? And also we gather all those like information about the embryos. What's the diagnosis? And also, as Dr. Quaas said, we also like counsel the patient. Ideally, you want to probably consider to do more IVF cycles, try to achieve like a normal or euploid embryos before we say, oh, okay, let's just do the transfer of a mosaic or abnormal embryos. And then we counsel the patient based on their genetic report, whether it's like a low level versus high level mosaicism. It's a single, what's the extent of a chromosome that involved? It's a single chromosome, it's a 2 chromosome, or it's a complex chromosome. And also depends on what's the specific chromosome, the aneuploid or like a mosaic it's involved. Then we give the patient based on whatever data we have today, kind of information or like the risk score, what's the priority that we should transfer these embryos. And then we give these patients, after the counseling, we give these patients like a mandatory 1 month to process and digest these informations before they make the decision to say, hey, we decided we want to go ahead and transfer these embryo. So I think these are like waiting time is important for a patient to kind of do some research, think about it, and probably investigate their resources, whether they want to do another IVF cycle or not. And then they can make a very informative decision, what's going to be the best for them.
Thank you so much. Well, before we go into the next question, which is what the outcome looks like when you transfer mosaic embryos, and I know some of the panel have some data. Let's look at the poll results. We have asked our audience about mosaicism rates in their organization. So 42% have below 5%, 36% have 5 to 10, and 22% have more than 10%. We asked them if, have you ever transferred mosaic embryos? 14% had excellent outcome, meaning a pregnancy, maybe a delivery. 28% moderate outcome, probably an outcome that is less than euploid, but obviously better than aneuploid. And 14% poor outcome. 44% never had a chance, never done a transfer of mosaic embryos. And we asked them what the cause, in their opinion, cause of mosaicism. 14% attribute that to embryo culturing, 22% to biopsy, 22% to NGS platform, 44% to genetics, and 56% all the above. And we asked, does mosaicism rates change with age? And 50% would say yes, and we can discuss this point in a little bit. And then 17% say no. And we ask, have you had any deliveries that were diagnosed with mosaicism? 14% said yes. I would like to know what the specific answer there. Riley, if you can ask the audience to kind of be more specific. that whether that newborn has been tested mosaic or not. 50% said they have not seen mosaicism in deliveries, and the rest unknown. And the last question is, would you recommend transferring mosaic embryo? 56% said yes, 19% said no, 25 not sure. I would like to get your guys' feedback on the poll. What do you think? Starting from you, Kim?
You know, one of the best studies, unfortunately, has not been published yet. It's a very large study of a transfer of over 1,000 mosaic embryos by Manuel Viati and his large group, but it is in press.
But before talking about the study, what do you think about the poll results?
Well, I think some of them are things that we think we are seeing. For example, I'm sure that a lot of people put that mosaicism increases with age, but it doesn't. And the reason it doesn't is because aneuploidy increases so much with age that it leaves fewer mosaic embryos around. So I think there's some parts that I agree with and some that I don't.
Yes. Very good. Klaus?
I would mirror exactly what Kim said. I don't believe that mosaicism increases with age because the aneuploidy rate just takes over. But I also think that a lot of people, you know, like, quite frankly, when we're looking at what causes mosaicism, I think all of the above is the right answer because none of us are really ever going to know. Because what compounds it is the platform. And the reason for that is I often will take an embryo that I know is its diagnosis, and I'll break that embryo up into 3 pieces and send that embryo to 3 different labs, and I get 3 different answers.
You're sneaky.
Yeah.
I like doing that.
It
I've
looks
done
like
it. I've
one
done
of
it
the
too, Klaus.
a patient has asked a question, what is the risk of transferring a mosaic? So one of the doctors want to elaborate on what would you tell the patient the risks are to transferring a mosaic?
Yeah, I think based on the data we have today, I think transferring mosaic embryo that was diagnosed from the trophectoderm biopsy, these embryos tend to implant less and miscarry more. So which means compared to euploid embryo transfer, these mosaic embryo transfers are associated with less implantation rate and a higher miscarriage rate.
Would you ever tell a patient that there's a risk of them having or delivering an abnormal child?
Yeah, definitely. So if we see the mosaic is like the chromosome that involved in the mosaicism can potentially lead to what we call viable aneuploid, then which like most commonly is, for example, trisomy 21, chromosome 13, 18, or sex chromosomes. Then there's a potential risk that the fetus might be involved and are like also have like a true fetal mosaicism. Or sometimes if this is a high level mosaicism, it could be this embryo actually is a true like a uniform aneuploid. So those are potential risks.
So is there no risk to the patient with the exception of potentially miscarrying if you transfer a non-viable mosaic embryo, meaning non-viable if it were to survive and be normal, that the genetic abnormality that exists in the mosaicism is not going to lead to a viable birth?
Yeah, so that's a reason. I think that's one of the strategy we use to kind of prioritize, like how do we choose those mosaic embryos for transfer. Mm-hmm. So those mosaic that was chromosomes that can potentially lead to a viable aneuploid is at the lowest bottom for transfer.
Right. Mm-hmm. Right.
Dr. Quaas, would you like to answer the same question? The risk associated with transferring mosaic embryos?
Yeah, and so the difficulty here is that there's so much about it that we don't know yet. And the other challenge is, and what completely blurs the picture, is that, you know, there's still sort of such a big debate about whether it's actually real. So there are other factors that keep being mentioned as reasons for mosaic results, like amplification bias, contamination, bioinformatic, artifact. I mean, all this PGTA, like, so basically, to put it into a broader context, the discussion about mosaics is an extension of the discussion about pre-implantation genetic testing for aneuploidy, because it's basically a side effect of the fact that we're now, like, you know, divided into this field where some people believe PGTA is fantastic, and then there are some that believe it shouldn't be done. And I think the mosaic is one sort of complication of the increased use of PGTA. And so I think that, you know, I actually happen to believe that rather than actually it being a biologic diagnosis, it's an intermediate risk category where you have PGTA and you classify embryos into favorable and then intermediate favorability, and those are the mosaics, and then unfavorable. And so I think it's so complicated to talk to patients about that, because I happen to also think that maybe the degree of mosaicism, whether it's 30% or 60%, is overrated in our assessment. Because when you read the literature, a lot of experts don't believe that that actually, you know, factors into, like, but we still are advised to prefer the quote unquote low mosaics over the high mosaics. And some people even are happy to transfer low mosaics, but not high mosaics. I think that that's completely unproven. There's so much that we don't know about it. But basically, when I talk to patients about this, I say that from the limited available data that we have, we know that there are live births from it. We know that the pregnancy rate overall is lower than with euploid embryos. And we also know that the miscarriage rate is probably higher. I don't think that patients should primarily be worried about having children with malformations, although of course that factors into it too, and that's sometimes at the forefront of patients' concerns. But I think it really takes a long time to adequately explain to patients what a mosaic embryo is, and then when they have an understanding of that, then they might actually feel more comfortable transferring it, because I think in some cases the worst outcomes are either no pregnancy or a miscarriage.
And this is going to lead us to looking at the data on transferring mosaic embryos. I think some of you in this panel have some data to share, and we have also a couple of publications that we will put out there. I will start with you, Tony. Maybe you could share with us your experience. I know that you have a couple of slides to share with us, and then we go to Kim from after that.
Oh, sure. So this is a study that I did in 2005. Looking, it was using a FISH technology, which is an old technology and flawed. But my early career, I did not believe that a day 3 biopsy and I have these really beautiful blastocysts would be abnormal. So I looked at the interstitial mass and the trophectoderm separately, the mosaicism rates. And what I found was that even euploid day 3 embryos gave us mosaic ranging between 11 and 100% on day 5 when I biopsied the embryos. And, you know, so my conclusion back then was that pretty much every embryo we have is probably mosaic to a degree. And, you know, like, and just like when we're saying today with the next gen sequencing, it ranges with where we call the euploid rate at. So I think my next slide is just looking at what our mosaicism rates are in our program, which we all talked about a little bit. My overall rates, 8.4%. We have transferred 2 embryos that were low mosaic, and we had 2 positive betas. We had 1 delivery from that. I'm not aware of any follow-up studies to see if that mosaicism carried on into the child, but I do want to go check that out. We haven't transferred any high mosaics. my personal opinion is I would love to do it. I would love to do this. And I know Kim's got some data he's going to share, but you know, in my opinion, if you're 45 years old and it's the only embryo you have and you invested all this money to get that one high mosaic, if it was my sister, I would probably transfer it. So, so I'm actually, you know, it's very good to be here to see how other people on the panel feel. Because right now in our clinic, we're not transferring the high mosaics. We will transfer low mosaic if that's all there is.
Thank you so much. Kim?
Okay. Once again, I've mentioned a little bit about a study that's been done that is not published yet. And Manuel presented this the other day, so I feel that he would not mind. I hope he doesn't mind that I'm showing this. This is his data, but it's just the effect of mosaics. These were 1,000 mosaic embryos that were transferred and 465 of these implanted. If we look over here on the left side, you can see the mosaic level, whether it's low or high, and then you can follow this to look at the implantation rate. Right here, this is 60% implantation. So euploids were a little less than 65. And low segmentals, high segmentals, 1 or 2 chromosomes, they had similar implantation rates. And then if you get down to the low complex and high 1 chromosome and high complex, they have lower implantation rates. But they still all have fairly decent implantation rates. Then if you look at the mosaic type and see what the implantation rates were, there you can find these over here. So I'm sorry, this is implantation rate. This over here is the birth rate. So you can see there's not a lot of fallout until you get to these low complex and high complex where you have a lot more of a miscarriage rate. And the most interesting thing that I saw from his presentation was that of these 465 mosaics that implanted, all of the ones that they had done testing on either by amniocentesis, CVS sampling, or NIPT, they found basically, I'm just going to simplify this, but basically every one of those samplings were normal. They were not mosaic. There were really, I think, 1 or 2 that were abnormal, but they were at a resolution that was much lower than could have been detected by the original testing. So I thought that was a great piece of information.
Wait, can you put that data back up, Kim?
Yes.
Because I'm like looking at this from a patient's perspective. And if I was a 42-year-old patient and all I had was 1 high mosaic and the doctor's telling me, you know, oh, it's too high of a chance of miscarriage, you don't want to do it, you want to do another cycle. Looking at this, I'd be like, well, what the heck? I'm seeing a 22% ongoing pregnancy rate there, or 18%. I would take that. If I was 40 something and that's all I had, give me that. I'd take it. I'd take the risk. And I think a lot of the patients aren't really aware that they still have a chance of having a pregnancy. Yes, it's low, and the doctors and the clinics don't want to take the risk of having, you know, the miscarriage or the low implantation rate. But as a patient, with that being all that you have, I think it's important to tell the patients that there's still a chance. Yes, you only have a high mosaic embryo, but yes, there is at 18, 15, 20% implantation rate. You may as well try it before you do another whole cycle.
You know, and I think there's something scary that just happened in Australia. There is I think it's got to be a class action suit so far. It's against a very large IVF clinic in Australia, and they are being sued because they did not transfer mosaic or aneuploid embryos.
Right.
Now, they used a non-invasive method of doing the biopsy. So they collected the fluid. But, you know, you can be sued for not transferring, as you can be for transferring the wrong embryo.
Very good. Riley, we have a little bit more data that were published on the outcome of transferring mosaic embryo. I have a couple of studies I want to just briefly go through. So in this study, they have 200 transfers. And if you just look at the implantation rates, so you're looking at, let me see, 55% versus 37%. So the 37% is the mosaic, the trisomies. And then you have 31% of mosaic complex. So what that means is mosaic embryos do implant. They have less chance than euploid, obviously, but they are definitely better than aneuploid. And then the live birth, you have 48% for euploid versus 24% for mosaic trisomies, and then 23% for mosaic complex. And so let's go to the next study. Next slide. So in this study, they found that the ongoing pregnancy was 39% in mosaic class compared to 63% for euploid. And the miscarriage rate was 24% for mosaic embryos compared to 10%. So they have, like Dr. Deng was saying, high risk of miscarriage and slightly or lower rate of implantation. So that's, I think that's probably and Dr. Quaas also said they are in the middle class between euploid and aneuploid. And I think that's how we should look at it. This is just an additional risk, a high risk of implantation failure, and higher risk of miscarriage, but still could lead to a normal pregnancy. I think that's the end of the slide. And let's.
Nabil, do you have data between clinics that you have generated that shows a difference between clinics?
It has been a challenge collecting pregnancy. We get pregnancy data, we get delivery data, but we haven't had enough mosaic results to consider a number, statistically significant number. So we have a very low number of embryos that are mosaic that have been transferred. We have seen pregnancy with mosaic embryos, but the numbers are just too small.
Yeah.
But I think that's probably one of the priorities that we will put in gathering data from clinics to get a good feel of how the outcome looks like.
Mm-hmm.
Do we have any other data on the panel that I think Dr. Quaas wanted to share one slide. What was that slide about again?
So I was actually slated to be on a panel discussion at the Pacific Coast Reproductive Society meeting that never happened in 2020. So there was a panel discussion at PCRS called "Should we transfer mosaic embryos or not?" And it was basically 3 members on one side and 3 discussants on the other. And I arbitrarily, not by choice, was assigned to argue against the transfer of mosaic embryos. And so I put together some slides, but the only part of it that I'd like to show very quickly, and I've very much abbreviated it, is one clinical study that I think is potentially useful. It's just very quick. I don't know if this is coming out. Let's show this. So basically, can you see this, or shall I swap the?
We can see it.
Okay, so with all this confusion, what should we tell our patients? And so I looked for a clinical study. There was a study from NYU from last year from Jamie Grifo's group that was published. And the title was, "What are patients doing with their mosaic embryos? Decision-making after genetic counseling." And so this is just a descriptive study of what their patients were doing. And so the question is, do we know that the transfer of mosaic embryos is safe in the short and long term? And so these are some sort of potential concerns. I'm not going to go into all the details of that, but basically persisting mosaicism, and then the percentage of mosaicism can predict the clinical phenotype, risk of abnormalities, and we don't really have information on long-term outcomes. Of course, this was geared towards, arguing against the transfer of mosaic embryos. But anyway, the experience from NYU was that 98 patients had only mosaics and no euploid embryos. And they basically looked at what happened to patients that decided to transfer them and what happened to patients that decided to do another transfer. So they had genetic counseling. And so then 30% of the patients chose a mosaic embryo transfer, 42% chose a new cycle. And so the pregnancy rates were 28% in the mosaics and 51% in the nuke cycle, and miscarriage was 24% in the mosaics and 12% in the patients that did a new cycle. But, and this is the big but, the characteristics of patients that chose to transfer mosaic embryos were that they tended to be patients who were older and had already done a higher number of cycles, which, I would consider poorer prognosis patients. And so therefore, I guess the question is, are we pushing our most desperate and vulnerable patients toward a suboptimal treatment? And of course, this was the question that was provocative. And I was, again, assigned to argue against the transfer of mosaics. And so the other part, and this is the last part of this, is after a mosaic transfer, it's recommended that patients undergo invasive testing to actually look at the karyotype of the pregnancy. The problem is, in this experience, only 6 out of 11 patients actually confirmed to do this. And so the summary of the experience at NYU was the pregnancy rate was lower, the miscarriage rate was higher, and there wasn't really 100% compliance with the recommendation to do amniocentesis in face of the uncertain outcome. So that is basically what I had presented from a clinical perspective based on the NYU experience from 2019.
Thank you so much. We have a few questions from patients that have asked regarding the mosaicism. Miriam, I have highlighted a couple of them. If you could give us those questions so that we can ask our physicians to address them.
Yeah, sure. The first question was from a patient who said that they had PGTA testing done and have given birth to a beautiful daughter that was their only normal embryo. The patient has another embryo from the same retrieval that is mosaic -17, and they're considering transferring. Patient says that they're 43 now, and because of that, they will not be doing another retrieval. So the first retrieval that resulted in 1 normal and 1 mosaic was done at the age of 41.
Dr. Deng, what's your recommendation?
Well, I feel like when I was trying to counsel this patient, I always tell the patient, what we have known nowadays is it's actually quite common to see mosaicism at a blastocyst stage. From either trophectoderm biopsy or from like early studies like a fish were done on the entire embryos. However, we don't know to what extent that these diagnoses from the trophectoderm biopsy can truly predict the outcome of the pregnancy or can represent the genetic status of the fetus. And whatever data we have from those like transferring mosaic embryos and lead to pregnancy, at least we know majority of those babies have normal chromosome copy numbers. And although in March last year, we had one report that the baby had the same mosaic like a type as what was diagnosed from the trophectoderm biopsy. But I tell the patient, truly we don't know. If the mosaicism at a blastocyst stage is the same thing or same phenomena that we see at the placenta or the fetus during the pregnancy or prenatally. And we just don't know, there's limited data that we can answer the question. But from the prenatal data, we know that some chromosome aneuploidy, especially if it's a viable aneuploidy, then it can cause like a physiological or physical or like a intellectual developmental impairment. So In this case, I think this patient is age 43. And I would say probably evaluate ovarian reserve and to see if there's any, she would consider to do another IVF to try to create more embryos and try to achieve like a euploid. If not, then depends on what's the level of the mosaicism. And also minus chromosome 17, I think it's potentially probably we can transfer. Very likelihood this embryo, if it's a true uniform aneuploid, then unlikely this transfer would lead to a viable pregnancy.
Thank you so much. We have another question for you, Dr. Quaas. Miriam, if you could read that second question for us.
Yes. How do you decide which mosaic embryo is safe to transfer if only mosaic is available? And to add to that, what are your thoughts about transferring both a normal and a mosaic embryo in the same cycle?
That's a good question. So in general, I would, to answer the last part first, I don't like to transfer more than one embryo ever, because most of the time, if PGTA is done and we have a high quality blastocyst, then single embryo transfer is nowadays, I would say, the standard of care. I would be very hesitant to do a double embryo transfer of a euploid and a mosaic embryo because it sort of clouds the picture. And so I would rather transfer them one by one. I think it's important to say one general and principal thing here. So, you know, I read another question in the Q&A, and it says, my doctor won't implant a mosaic embryo. So, you know, in general, I think one of the art pieces of being a reproductive endocrinologist, a fertility specialist, is to create situations where 99.9% of the time, you're on the same team, on the same page, and you explain to patients the rationale for everything that you do and why you do it, and that you would also do the same thing with your sister or your wife or your cousin. Because I think that sometimes, you know, obviously I'm not a perfect physician either, but I think sometimes physicians make these blanket statements like, we will not do this or we will not do that, without explaining the rationale. And most of the time, if you spend the time counseling and talking about it, then you can get on the same page with your patient, and the patient wants the same thing as you. So, but going back to if you have multiple mosaics, that was the other part of the question, I would take into account the level of mosaicism, even though, again, some of the experts, and I looked at this reflection about mosaicism by Dr. Monet and Dr. Grifo and Dagan Wells from the UK, and they basically gave arguments as to why the percentage of abnormal cells may actually be meaningless in terms of predictive potential for the remainder of the embryo. And they, in their commentary, wrote, our recommendation is to report all mosaic embryos detected as mosaic, irrespective of the percentage of abnormal cells. But the level of mosaicism clearly goes into it, the chromosome involved also. And then lastly, I guess the morphology of the embryo is also important, because let's not forget, we've done years and years and years of decision-making on which embryos to transfer based on morphology.
Thank you so much. I'm going to take the next points just as a follow-up of your comments about morphology and mosaicism, because we had a question that is related to that. So the question was that you have embryo, AA grade embryos and CC grade embryos. What is the distribution of mosaicism rates between the two? And the decision of transferring embryo, would that be better based on embryo grade or whether the embryo is mosaic or not? For example, if you have a CC grade embryo that is not mosaic but is euploid, and you have an AA grade embryo that is mosaic, what is the priority? I'm gonna direct this to our embryologist first, and then if you guys wanna add something more, then we can do that. I'll start with you, Klaus, if you can tell us what is your opinion about that.
We would transfer the euploid embryo first, and then would save the the abnormal embryo for later. But what we would counsel the patient is that where morphology is important is we would counsel her in terms of expectations of surviving the freeze thaw process. In other words, we would say the embryo is euploid, but there's a slightly greater risk that either the embryo may not survive the cryopreservation, or it could have some damage as a result of the cryopreservation. So we try to manage the expectations from that perspective.
Thank you so much. Kim, what's your perspective?
Well, I think it should be, I think Klaus's approach is what probably most of us do. I mean, that's very logical. But, you know, you always come to the point, and that is if you have a CC embryo or a high mosaic, which one do you transfer? And
if you have low mosaic, low mosaic, AA.
I'm sorry, low mosaic and a CC. So let's say, I think you can only transfer that I think you should transfer it based on data. And there is actually going to be a web-based method of determining that based on implantation rates, live birth rates. And that same group, Vietti, that I mentioned, has this unpublished paper. I was told that they will be putting this sort of rubric on the internet where you could enter the grade of the embryo and enter what type of mosaicism and what level of mosaicism, and it will guide you to help you determine which one will have the best chance of producing a live birth.
Thank you so much. Tony?
Well, just like Kim and Klaus both said, if I was, even today, if I was in front of my doctor, primarily we'd say, got to transfer the euploid one first and then come back with the CC. However, last Tuesday, based on this paper that is coming out, Kim refers to here, Manuel pointed out that a CC euploid embryo has lower chance of pregnancy than a, AA or even a BB low mosaic. So if I had to choose, I would have the conversation with my doc based on that study that is coming out, because you still have the euploid, and you definitely want to try to take advantage of that embryo. And as Dr. Quaas said, it never would transfer them together.
Very good. Debbie?
Same. Obviously we're in the mindset that it's euploid, but I think there is going to be a turning of the tides as more data comes out on the low mosaics and the pregnancy rates, and that I think we're going to start to shift our train of thought that a low mosaic may not be as bad as we think, and a beautiful AA low mosaic might be the embryo of choice in the future. But I think we need to see a little more data come out, and we need to have a few more discussions on that before I think that happens. So I think right now we're all kind of in the same train of thought that we're going euploid all the way. But I think we're all definitely also open-minded enough to look at the data and change our train of thought with more information that we have.
Thank you so much. And how about you, Dr. Deng?
Well, I agree with other speakers. But like from the clinical perspective, I would tell the patient, although CC has a lower successful rate than AA, but it's not zero. So although the coming data is encouraging, and we see low mosaic, high grade embryos might have a good implantation rate or successful rate, but we also have to keep in mind that with limited data right now, we truly don't know how much this mosaic diagnosis at a blastocyst stage can truly predict the fetal status. And we do see prenatally mosaicism in almost like every chromosome. And for those prenatally diagnosed mosaic, and a significant portion of them, actually baby is impacted and have negative phenotype. So I think like while we're counseling these patients with encouraging data coming out, we still need to keep in mind that prenatally, those mosaic chromosomes can potentially impact the fetus or the newborn in the short term or long term, physically or intellectually. So I agree. I think like with more data coming, we probably will switch from this binary euploid and aneuploid classification to like a classification system, like put the mosaicism in intermediate category. And also in this category depends on how much like or what extent these chromosomes are involved, what's the level of the mosaicism, what the specific chromosome that's involved. Then we can give a score of risk, and then that will be very helpful to guide the clinician and the patients to make the clinical decision.
Thank you so much. And another point to add to this is when you have a mosaic results, not all mosaics are the same. Some mosaic results are affecting one chromosome or two. How do you make, and I'm gonna add one piece of data to this, is that when you look at miscarriages, 65% of miscarriages are due to single trisomies, and the monosomies it's a minority. It's a very small percentage. So taking that into account, how would you counsel a patient that has a monosomy, mosaic monosomy versus mosaic trisomy, one chromosome versus the other? Do you look into that context, Dr. Quaas?
Yeah, well, that's a kind of dicey area, because again, in the reading that I did on mosaicism, sometimes it said that if you biopsy the trophectoderm, you get a monosomy. Sometimes those are the embryos that have a corresponding trisomy in the inner cell mass if it's a mitotic error. So I think that it's maybe too early to tell whether that should be taken into account. I think the clinical data will help us counsel patients more on this. So I think that there's so much still to be decided. And so I think that, the overall take that I have at the moment is that it's generally wrong to say I never transfer mosaics or I always transfer them. I think it always needs to be done on a case-by-case basis. And I just wanted to add a quick example. The last 2 mosaic transfers that I did were actually in patients that originally came to me, one of them to do PGTM. So she was a carrier of Fragile X and didn't want like her child to have, like the risk of mental retardation. So she came to us for PGTM. And the other one was somebody who wanted to do gender selection. So these are couples that come to us for a completely different genetic interest, but because we always throw PGTA in there as well, we're sort of forcing this on them. And so then the only thing that they had left, the only, in one case, Fragile X-free embryo that they had, and the other one of the gender that they wanted was mosaic. And so I did the counseling. And we as clinicians, it's easy to say, just do another cycle. People need to understand what it means to do an IVF cycle in the United States. It's over $20,000. It's, physically challenging. It's emotionally draining. So I think the decision needs to be made with the patient on a case-by-case basis.
Thank you so much. We are approaching the end of this webinar. We have just one result from the poll that we're gonna show in a second. Then I will give you guys a minute to introduce your organization. And after that, we will wrap up the webinar. And Riley, if you can just post the last poll that we have. Okay, meanwhile, I'm gonna let the panel, okay, the results are, we asked the audience if they liked the webinar. So 88% did like it, said yes, they find it useful, and 13% says somewhat. So thank you so much for this wealth of information. And then we asked them if they wanted to see a webinar like this in the future. 90% said yes. Thank you so much. I will let you guys introduce your organization, and then I will make just the announcement for the next week webinar, and we will close this webinar. And I'll start with you, Tony.
Well, thank you, Nabil, for the invitation to be here today. And I actually am a multi-site lab director within the Prelude Fertility Network with Aspire Fertility. I also am the founder and trainer at Embryo Director IVF Academy here in San Antonio, where we train embryology and andrology students.
Fantastic. Debbie?
I am the co-founder and lead trainer at World Embryology Skills and Training Center that we just opened up in the San Diego area. And we train, we're recruiting new embryologists into the field and training a 3-month program where they know nothing, but they just have a degree in the life sciences. And we train them from the ground up. When they leave, they're fully trained in ICSI and biopsy and ready to go into a lab. Because we need embryologists, so go Tony.
And you are at the center. I can see some picture like an image of
yes.
It looks beautiful.
We just started our first 3-month course this week, so
well,
we're going.
It looks nice lab, Debbie. It looks awesome.
Thank you. Thank you. I want you guys all come visit. Anybody can come visit.
Would love to.
Love to have you.
Very good. Thank you so much. Klaus?
My name is Klaus Veemer. I'm the lab director here at Palma Fertility. We are located in the suburbs of Seattle, Washington. I've been here now, I've been doing human IVF since about 1984, 85. So I've gotten to see a lot of changes in IVF, back from doing day 2 transfers all the way to now doing day 5 and day 6 transfers. So it's been awesome to be part of this community with so many great people like that are on this panel. It's been one hell of a ride. Thank you for letting me be part of it. Thank you for letting me be part of this panel. It's been really awesome. Thank you.
Thank you. Kim?
I'm the science director at the World Egg Bank. We're a unique egg bank. We are one of the longest egg bank that's been around as a self-standing egg bank. And we do everything in our own clinic. We don't farm out anything. And I've enjoyed working with everyone here. There's some people I don't get to see very often because of COVID. So it's nice being able to see you on this site.
Thank you. Thank you so much. Dr. Deng?
Hi, I'm a clinical fellow at Stanford University. Thank you so much for having me. It's such an honor to be in this webinar. Just for the audience, I want you to know that Stanford, we have this ongoing TAME study, transfer of abnormal and mosaic embryos. If you're interested in, or if you're a patient and considering to know more, you want to know more about this research, you can always find the detailed information from our website, or you can direct message me. I use Instagram, Think Fertility Dr. Deng, and I can connect you with our research team.
Also, I think if you give us the information about the STEM study, Riley can send it to the patient that have attended this webinar in case if they are interested.
Sure, will do. Thank you.
Dr. Quaas?
Yeah, so my name is Dr. Alex Quaas. I'm originally from Germany, as everybody can tell, but I've worked in the United States for the last 17 years or so, East Coast, West Coast, Midwest, also for a short stint in Switzerland. Currently, I'm at Reproductive Partners Fertility Center in San Diego, affiliated with UCSD. And if anybody wants to follow me on Instagram, this is my handle. 2 A's. Everybody always misspells my name and puts 2 S, and then they wonder why they can't find me.
Thank you so much. Thank you. Well, with this, we're coming to the end of the webinar. Next week, we will have another webinar on the lab side, managing quality control and quality assurance in the IVF lab. And the following week, we will have another webinar on recurrent pregnancy loss, what to do next. Thank you so much for this I had really great time, discussing Mosaicism, very good topic. Thank you so much, and I will see you next week. Thank you.
Thank you.
Bye, everybody.
Bye.